So good morning, everyone. I hope you had a great dinner last night. You well deserved it after having worked so hard all day yesterday. Are you ready for another day of solving the world? Good. Today we're going to be more specific and go into details of what needs to be done now that we have the global action plan. How are we going to do more in detail? Because the operationalization of this action plan is not obvious. We have 3 keynote speakers here this morning, 2 who are here with us, and on Skype will be Ramanam Laxminarayan, who is today in the White House advising President Obama how to fight antimicrobial resistance. Even if this morning's speakers are mostly perhaps pointing towards the seminars, the workshops later, there is a common denominator here, and that is money, or I should say perhaps cost. Because as we move towards a world with a more rational use of antibiotics, and we will all gain from it in the end, there will be costs, and who is going to pay, and what could be a fair and just distribution and reasonable distribution of costs. And that also, of course, includes fair price for access for people everywhere who need medication. We will start then with the 2 who are with us here in the flesh. So I would like Brendan Barnes to come on stage with Manika Balsagaram. Where are you? Hi, welcome.
Hi. Shall I start?
Yes, you shall start. You can sit down.
Okay, well, good morning, everyone. I should say, first of all, I'm a little bit annoyed with Sweden. You asked me to sort of wake you up before you get Manika. But the second reason is that I drafted a presentation for today, and after 10 minutes of listening to Otto yesterday, I realized he'd said everything that was even slightly original that I was going to say. But his points were good, so I think they merit repetition. I wanted to cover, I think, 5 things to talk about milestones and results, looking forward, and underline that I think the outlook is still uncertain, and then coming to the brief of the session to sort of point to key actions. But I think talking about milestones, if we look at what's already been achieved in the last, 7 or 8 years, we've made significant progress in public sector sponsorship of research. We've seen some concrete innovations in terms of new incentives, not just for drugs, but for diagnostics in other areas. I think perhaps most importantly for the industry, we've seen the medicines agencies take on the problem of how do we actually run clinical trials in this area, and I think their engagement has made a huge difference. We've had a sort of a drumbeat of regular communications about the problem. I know, I've talked to people over the years about how do you communicate the nature of this problem, and I think one of the reasons we've got to today is because between ECDC, REACT, the O'Neill report, MSF, there has been a regular background noise about the problem, which is important. We've seen legislative action in the US, and John Ryan yesterday told us that the EU is now going to look at where are the gaps in their own action plan, so that's great. And again, very importantly, from the start, this has been an inclusive approach to the problem, and everyone has been involved. And that's an easy thing to say, but certainly a few years ago, it was not obvious that we were going to tackle things that way, and I think we've benefited from doing it. Finally, in terms of milestones, a milestone of a different type is, of course, Ebola, which I think woke a lot of people up to the natures of outbreaks of communicable diseases, but also their impact on health systems. So something that perhaps was a little bit difficult for people to grasp in the AMR context suddenly became very concrete when we were faced with that issue. The results, I think we have more companies in the field. If I talk from the perspective of the industry, I think both SMEs and we see some large pharma companies re-engaging. We're starting to see some approvals of new antibiotics. And I'm not close to this, but my impression from conversations that I've had in the last day is that we also have the start of a sort of grassroots movement dealing with best practice in terms of community education and, you know, best practice in terms of prudent use, which I don't think was there a few years ago. And finally, and most importantly, we have the globalization of the issue with the WHO action plan and the issue being on the G7 agenda. A sort of, let me dive in then in terms of looking forward to talk specifically about the incentive issue. So I think a couple of our workshops have been about the new business model. I think what we've achieved in the last few years is there is a degree of consensus about what we need. We need a diverse pipeline of antibiotics. I think we've sort of moved beyond the idea of saying there is one perfect antibiotic and that is the only thing we should be looking for. I think people recognise we need diversity. We need to anticipate resistance rather than respond to it, which has implications for what you support and when you support it. We need to eliminate the incentives associated with volume sales. We need a model which enables global access, and it should be a model that reflects the societal value of antibiotics. So it should encourage companies to continue investing in this area. I think yesterday we saw a number of people flag up this idea of the lump sum payment. I think it's actually a sort of cluster of ideas, but they all have a similar characteristic that you're moving away from reward for the number of boxes sold. And this can perhaps be linked to a commitment to supply. But the underlying idea is that what society is paying for is the ability to combat resistance, not the actual pills themselves. Now, I think where we are is those points are made are very important points of consensus, if indeed we do agree on them. And we're at, if you like, a sort of design phase where you're thinking about questions like how big should a lump sum be? What should be incentivized and when? You know, at what stage in the development process? How do you deal with differences in the evidence base as you start to use new agents and you find out they work better or worse or differently from how you anticipated they would? Do you have a sort of a baseline level of incentive and then something else for truly breakthrough innovation? These sorts of things have to be figured out, as well as how you integrate the idea of new classes with the potential for combination products and repurposing of old products. But the thing that I wanted to emphasize is I think where we are is these are all problems that people are thinking about. A lot of the answers or potential answers are already out there, and they're things that we can solve. So these are not barriers to progress, even if they're things we haven't entirely thought through. So at this point, I would say, you know, I think things are very positive. A lot has been achieved. Now, why do I say then the outlook is uncertain? I think the outlook is uncertain because we've seen a revival in pharmaceutical industry pipelines, but it's relatively recent. We recognise, and I think this has been a theme of the conference, that all of our discussions are overshadowed by financial considerations. We need to increase the level of investment in this area. We need to increase the level of investment in pharmaceutical R&D. We need to increase the level of investment in health systems across the whole system, and it is an integrated system. We need more investment. We have the UN Sustainable Development Goals discussion taking place later this year. I think I would certainly agree with Otto that if AMR doesn't figure in that discussion, then that actually becomes a serious problem. You can say the SDGs are sort of somewhere up in the stratosphere, but I think it's a conflicting message if it isn't very clear that AMR is on the agenda as part of the output from that process. we need to figure out how these new antibiotics will be distributed and used. A lot of what I've talked about the business model, is essentially about how do you get a new antibiotic to the point where it's been approved. But maybe this is a bit provocative, but I think to some extent you can de-link those problems. They are ultimately all connected, but you can think about how do you create a system which generates new innovation in bringing things to the point of approval, and you can separately think about slightly different issues about how do you actually ensure that people get the antibiotics that they need, and how do we manage an appropriate use. There are linkages, but there are also ways in which you can progress those two things separately. I think we have a WHO plan. We have an excellent WHO plan, but I'd like to suggest we need a higher level of political support to get it realised. I think if we saddle the WHO plan process with carrying the whole of the water that's needed to get this achieved, then probably the plan will fail, would be my concern. And coupled to that, we need to build and strengthen further the sort of idea that we have an interconnectedness and there's a global political commitment needed in this area. We have the G7, but what is that going to turn into? I think we need that level of global commitment. So in terms of actions, a few sort of questions for people. First, decide whether the EU and US can take the lead in building this new business model. It should be a global business model, but you always have this trade-off that the more people you want to participate, the harder it gets to actually initiate something. Is there something the US and EU can start? As I mentioned, make sure that communicable diseases get the necessary profile in the SDG debate. I think we do need solid financial commitments. The reasons I made the points about the business model are that a lot of good thinking has gone on. I really think that we're at the point that if world leaders don't actually say, yes, we're ready to put some money on the table for these things, the danger is that we get involved in another cycle of analysis, whereas the reality is the key thing now is to say, yes, there is money available to fix this problem. I think we should build on what I believe is success that we've had in looking at the limitations of the existing R&D model to look at what we can do in terms of prudent use and distribution. And I would ask people to, not ignore the industry in that. People tend to look at us as the people who do the development and bring the molecule through to approval, but we may have a role to play in addressing access and addressing how we manage the relationship between development for human and veterinary purposes. So we have a continuing role, I think, and we would like to be part of the discussion. So, in summary, I think I think a lot has been achieved. I do think we're at a sort of critical stage, which is things can go forward or backwards, and I think the key thing is now that world leaders need to actually deliver on the good policy thinking that's gone on and actually demonstrate there is also a financial commitment to support it. Thank you.
So do you think that's going to change? Please come and sit by Monica. Do you think this new engagement that we've seen from world leaders, for instance, do you think that will make a difference?
Yes, but I think the danger is that they don't take action. I think we've, in a number of channels through WHO, the multiple channels that are represented here, we've had a lot of action, a lot of thinking about what needs to be done. And there's a degree of clarity and consensus there. But if people don't actually say, this is how we think we're going to fund this at this point, then I think the danger is we get more sort of paralysis through analysis. Yeah.
But also, how do you say, at some point the industry will have to set a price tag somehow, this lump sum?
Yep.
How will you decide how big that would be? Because also, the more public mobilization you create, the higher the funds could be.
In the talk, I deliberately said, I don't think we've nailed that problem down yet. Kevin Utterson yesterday talked a bit about where the Chatham House process has got to. What I wanted to say was, I think the degree of discussion that has taken place means that that should not be a barrier to moving forward now and making the financial commitment, because we know we can fix that problem. You know, we will find a formula, a mechanism for doing this.
Okay. Monica, what are your comments? Please sit down.
I would definitely agree, I think, with the final message that, you know, we can get into a stage of paralysis by overanalyzing things. And I think that at the same time, you know, we all want to make sure that we hammer out some key details. But I think it's important to keep moving forward while we work out some of these details. And I actually think that at the end of the day, we probably will be able to work out these numbers. I'm not really unduly concerned about that. It's just that we haven't got the right people around the room to really seriously work on it and have, you know, information as a basis to start working on that level of detail. And in parallel, as I will mention in my talk, I think there are other things that we can start doing, I think, to catalyze that. My biggest concern is really that I don't think people should underestimate the power of lassitude. I mean, we've seen it. I mean, as an organization living through the last year, it was just unbelievable to see, I think, the level of inaction that the world is capable. And we've heard these never again messages and, you know, lessons learned and all. We've been through all of these exercises. I've certainly lived through that in various different problems. So I'm, you know, healthily skeptical, but I think it does require us to be very, very strong advocates for change. And I think one of the big advantages we have when we talk about AMIs, we have, I think really for the first time in a long time, we have people from very different entities coming together and different backgrounds coming together, delivering some common messages. So while we need some big champions, it's us together, the little champions, that make a huge amount of things possible, and we are the strongest advocates for change.
We'll let you go on with your talk.
Sure. So I'm actually probably, rather than, I will probably touch on some of the things that Brendan mentioned, but having just been through the World Health Assembly the last couple of weeks, I probably thought it would be useful to have a few comments about some of the aspects of the Global Action Plan, and as we look at moving from an action plan more to a global operational plan and operational implementation. So just in terms of overall perspectives, I think certainly from our point of view as an operational organization, we really see two things that need to happen. First of all, a lot of ground-up efforts in this area that's going to happen in parallel with international and regional strategies being implemented. And for us, we still see what is happening in developing countries as the key. It's not to say that we think that developed countries have a very important role to play. They do, and I think the role particularly of setting examples and providing a degree of leadership is important. But we also feel developing countries can set examples and can provide leaderships, and often some of those countries that are leaders in certain areas can be real catalysts for change. We see the Global Action Plan as one of many steps. So on the one hand, we don't want to trivialize it, but on the other hand, we should see it for what it is. And there are global action plans for lots of different things in WHO, so the key is how we need to operationalize this. Speaking of WHO, our question is who, or WHO, who coordinates and supports. And I think that, we really need to kind of think very carefully about the role of, a normative agency like WHO. We have questions about a donor-driven model. Do we want a donor-driven model? Do we want a more investment model, or a model that countries see as all having a role and a stakeholder in? And I think one of the criticisms we've had in the past in other areas of real progress in global health is that we are still very much relying on a donor model, and that raises all questions around governance and ownership. Money is important, and I think there is a very important question on where the money comes from. Who's going to pay for all of this? I think Brendan had asked that question. Country-level prioritization goes up to the first point that I made. At the end of the day, there has to be clear prioritization of certain elements of the global action plan. And I think the last point, health security versus global health. I mean, this is more of a reflection that we've made, I think, in the last months. AMR is kind of an unusual topic because it currently sits in the health security agenda, which I think has helped to politically advance it. When we talk about implementation, I think it's, for us, questionable whether we really should be thinking of it from the health security perspective in terms of how we advance elements of the global action plan. And certainly from our experience in Ebola, we don't see any value of the health security agenda in terms of what actually happened in terms of responding to that crisis as well. I would want to make a kind of very early plug here for diagnostic tests, which I think are going to be crucial for the implementation of the Global Action Plan, ranging from the need to improve surveillance in developing countries to helping to update, improve our clinical guidelines and how we manage patients on the ground, antibiotic stewardship, the role diagnostics can play in future clinical trials, and also in infection control. So there's a multitude of different areas, I think, that are part of the Global Action Plan where I think diagnostics fit in. So I think this, to us, is certainly an area that needs significant attention. And so when we talk about innovation, we often talk about this from the perspective of developing new antibiotics. But we strongly urge, particularly, I think, people who are in companies and developers, that the field of diagnostics is certainly an area that needs significant attention and funding. And of course, we need to think about tests that are also going to be adapted and can be adapted for low and middle income countries. On the other hand, while we are waiting for a lot of these new technologies to be developed and to come on the market, we need to really seriously consider building microbiological capacity on the ground. And actually, this is a question we are asking ourselves as an organization. What have we done in this for the last few years? And certainly we need to improve our own efforts in doing this in our operations. And of course, I think the last point is very clear. We need to somehow work in developing algorithms and integrate clinical algorithms with diagnostics. But we also have issues around antibiotics. We have issues around accessing quality-assured sources of antibiotics, and incredibly, even obtaining quality-assured sources of penicillin has been a problem. And there's also the issue about how we rationally use what are the best regimens for some of the, well, I would say last-line antibiotics that we have, which are really revived antibiotics. There are issues around access to later-generation antibiotics like imipenem. We've not been able to access it in certain countries. There's obviously the issue around the antibiotic pipeline. I won't discuss that because I think a lot has been said about that. But on the other hand, also to emphasize that access, that high mortality from infections, particularly in the under 5, remains a major problem. And I think access to us is still the central discussion point. So actually, sorry, this is the old version of the presentation. There's actually a slide missing. But I can talk through that. In fact, just relating to access, we do talk about an access cascade internally in MSF. Certainly something that we try to do to explain to our operational directors the importance and value of access, and particularly where we see barriers in access. And for us, it starts off in many different levels. It starts off from simply prioritizing areas of research and development for future access. And that is something in AMR that we clearly need to do for drugs vaccines and diagnostics. Then I think there's an issue around actually the R&D being done, being adequately financed, and it being, I think, done in a timely fashion. There's issues then around registration. So clearly we also see often tools, drugs new drugs coming onto the market, but struggling to obtain registration in multiple different low middle income countries and obtaining products there. There's issue then about procurement in terms of how products are rationally procured. There's also issues around supply, and certainly for a lot of infectious disease, it's to get quality assured supply of drugs can be quite tenuous, and we've even had periods for certain diseases where we've had gaps in supply, which I think is quite problematic. Then when you look lower down, I think even when there is supply of these products, what happens at country level? The products have to come into the country, then they have to be distributed to sites, peripheral sites, and then there has to be rational use of these products. And then the final aspect of that, clearly, is what happens at the patient level. Do patients trust the healthcare systems that they're in? Are they going to take and comply with prescriptions or even medications they receive over the counter? And then there's the whole feedback loop. Do what we have in terms of policy that's made somewhere between registration and supply of these products, are they still rational? Are they still up to date? Certainly, we saw, more than a decade ago, this was a very topical issue in malaria. So when you look at that whole cascade, I think what you do see, it can be very daunting, but you see there are many different areas where when we talk about AMR, we're actually talking about specific blockages in that access cascade. And that's why for us, it ultimately still boils down to an issue about thinking about access in a very integrated way. And I think for us, AMR is still, we talk about access, of course, and I think this is important, but we need to integrate that more into access. We have a few comments around the Global Action Plan. I won't go through these in any detail, but these were actually, this is actually more or less made public by briefing papers that we released in the World Health Assembly. But I think, some of the important comments that I'd like to bring up is that, first of all, when we do talk about knowledge, say, for instance, Objective 2, we do talk about knowledge and evidence base, we should also not forget some of the most vulnerable patient groups. And I think there is, of course, an importance to look at the macro picture, but sometimes the micro picture is important, and particularly the most vulnerable, the most susceptible to dying, those are important groups to look at, and those are often very complicated groups. It's also a passing comment to say that, we often talk about equity, but not all people start at the same baseline of equity. Some people have greater needs than others, and I think that's a factor to take into account. Also, I think we do need to develop metrics. Metrics are going to be very important, particularly when we look at the misuse of antibiotics. But we would also argue that it's important to look at metrics on the use of antibiotics, on the access issue. And somehow I think this needs to be brought up when we look at the overall metrics that are developed for the Global Action Plan. We talk about reducing infection. We certainly need to focus on education and training, but we also need to invest in infection control measures. And I think this is, to us, very, very important lesson that we are learning and continuing to learn in terms of what happens well and doesn't happen well in our clinics, health centers, and hospitals, often places we are working in close collaboration with ministries of health. I think access to vaccines, and vaccines being a very important tool in prevention and reducing the use of antibiotics, I think is key, whether you're looking at human or animal health. And therefore, I think some of the efforts made here have been remarkable in the last decade, but I still think there's a lot of work to do in continuing to improve access to key vaccines and also continuing to work to make these vaccines more adapted to the conditions, particularly of developing countries. And certainly, then, when we talk about optimizing the use of antimicrobials, once again, I will make a plug here that the use and value of diagnostic tests are key, and I think this fits in very, very kind of neatly into Objective 4. But I also think, additional comments we have is that WHO has an important role to play here. I know we know that WHO are not, kind of the world's most popular organization at the moment. but they're still our World Health Organization. And for better or for worse, we have to try and make things work in the WHO. And actually, there are very important mechanisms that have been working in the WHO quietly and very effectively in the last couple of decades that have made a real difference in access to medicines. And of course now medical devices and vaccines. And we need to use this and exploit these mechanisms, I think, for AMR. Particularly when we look at things about how we are setting policy and also things around assessing quality and on some of the regulatory issues of antibiotics and future antibiotics as well. I think the last point, clearly, this is something that was discussed, I think, quite a lot in the last day. But clearly there are very important things that can be moved forward. There are many things that we are commonly agree on. The details do need to be worked on. But now we need to see concrete actions to make these things a reality. And I will finish off by touching on some of this now. So what next? Well, I think, as we discussed earlier, I think the political commitment at country level is going to be critical to implementing the Global Action Plan. Clearly, for us, this always, in the end, somehow boils down to an issue of resources. And I think, to us, resources are the strongest expression of political commitment. And I think that's where the proof is always in the pudding for us. There have been some very positive steps. I think, the US government's, UK government's Fleming Fund to help response capacity in low and middle income countries, I think is a very welcome start. And I think this, particularly in implementing things around surveillance and infection control, improving prevention measures will be, I think, extremely key. Going back again on WHO's role, just to repeat that I think this is now, we have to think of it, particularly when we think about WHO and what WHO can do, it is going to evolve beyond health security. And certainly in the framework of WHO as an organization, we strongly believe that this is going to start at country level, on the ground, and I think WHO has a role to play in helping countries to implement the Global Action Plan, but also at regional and clearly at headquarter level. And as I've mentioned there are things that are currently functional in WHO, that WHO have been working on in this area of AMR around innovation, policy of rational use, essentials medicines list, the pre-qualification program, regulatory strengthening, health system strengthening, that are actually very key facets of implementing the Global Action Plan. And we should ensure that these existing programs have the resources and the political support, I think, to help implement parts of the Global Action Plan. And then I think the last question that has been kind of bandied around, do we need a global fund-like structure? Well, I would broadly say yes, but I think there are a few caveats. I think we need to look at good governance, and this is key, because I think in the last decade and a half, we've had a proliferation of global health actors that have played a very important role in helping a lot of key issues progress in global health, but they've also, I think, played a role inadvertently in, I think, weakening our global health governance system, and this has had some profound consequences. And I think that's why clearly we need to think very carefully about strengthening other actors when we think about looking at a global fund-like structure rather than weakening other actors. We should not look at just merely market shaping or procurement or purchasing of commodities. All of those things are important, but those are largely what the current global health actors, big global health actors like the Global Fund, UNITAID and Gavi focus on. I think it has to clearly go more than that, because we are looking at issues of how we stimulate research and development, but also rational use and promote access. As I said, I'm not convinced that the current global health actors we have can meet this task. That's a personal opinion, not an organizational opinion. But I think, therefore, I think there's some specific things to think through if we are talking about an entity that can meet some of these challenges, or at least facilitate some of these challenges. And I think in the last slide, this was really taken from an article that some colleagues and myself published recently, just before the World Health Assembly. And it's really to make a call for complementary, sustainably financed global R&D fund, really to complement, in many ways, all the other entities we have on the left-hand side of this slide, who are also current funders or potential funders in the field of AMR. But what we did call for, importantly, was to do a couple of things. First of all, to marry this, I think, with some of the existing work that is happening, particularly around the issue around the Global Health Research and Development Observatory and I think the mechanisms that can be used for priority setting, monitoring, and coordination. This is actually currently sitting in WHO. To also then look at some of the key, I would say, public health issues that have been put on the agenda recently. AMR is one of them, but we also have emerging infectious diseases like Ebola and neglected tropical diseases. And we've been working on these issues for very, very long time. So we do see a lot of crossover, a lot of overlap, and even potentially scientific overlap between these topics. And I think we have to be very careful not to do as what the slide is doing, which is to silo them into three different things. And then I think, obviously, I think the added value clearly is that then when you do think of concepts around delinkage, open innovation, licensing for access, these are things that are amenable strategies in these different disease areas, or I would say different public health issues, that I think actually this a global fund for R&D can help support. I would say that, of course, we are not looking for a comprehensive fund to cover everything in these areas. I think there are clear priorities that need to be determined in AMR, in emerging infectious diseases, in NTDs, and that clearly can be the role of that will come out of this priority setting, monitoring, coordination. And in parallel, I think what will need to happen is that a fund can play a very important role in increasing the coordination between these different funders on the left-hand slide, and we see that as real added value. So I'll end there, and I'll be happy to take any questions on this.
Thank you, Monica. I just heard now that, could I ask you to take your chairs, gentlemen, and bring them just a little, move them to that part of the stage. I want you to stay on stage as we are calling in Ramanam Laxminarayan from Washington. So we'll have time for questions after, I hope. Hello?
Hi.
Hi. How are you doing?
Very good, very good. It's a bit early in the morning, but I'm glad I'm able to join you one way or the other.
So, are you keeping President Obama happy?
I think President Obama is keeping us very happy, is the right way to put it.
No, but are things going well?
Yes, yesterday there was a significant meeting at the White House, which involved the secretaries of the Health and Human Services, as well as Agriculture, head of CDC, President Obama's National Security Deputy Advisor, the head of counterterrorism. So a lot of people who you would not think would be interested in AMR, who stood up and iterated the fact that the US government is now switching to a policy of all of their actions having a pro-antibiotic effectiveness stance, which means everything that the federal government now does will now keep in mind the impact on antibiotics, which is significant because it means that all food bought for federal cafeterias will now be preferably antibiotic-free. Everything that the US government does through its VA system will now work in the direction of preserving antibiotics. And as you know, the federal government is a fairly significant entity, and when they set the tone, it certainly changes a lot of things.
That's great. You're getting applause here. So we'll turn now to your presentation. So if you can walk us through it.
Sure. Okay. So thank you all, and I know it's hard to always listen to a presentation on Skype, and I truly apologize. I had all intentions of joining you all in Uppsala, but this was a historic meeting that was organized at very short notice, was postponed from 2 weeks ago, and therefore, there was no choice but to be around to see this momentous occasion when the U.S. actually, seriously takes on board the issue of antibiotic resistance and that too from the White House, something which I would not have dreamt would happen 3 years ago. And the last time I was in the White House was, 12 years ago to have a similar discussion, but there was no commitment at that time, and now that has changed significantly. What I wanted to talk to you about was the economics of antibiotic growth in livestock, which is an issue which is now, again, in the context of yesterday's events, where a number of producers and people who resell meat, all the big Tyson Foods, Purdue, all of these folks, as well as folks like Walmart, are now committing to systematically trying to reduce and phase out use of antibiotic growth promoters whenever, at the fastest possible pace. And they've made a commitment at the highest level from their CEOs. So this is something we can really hold them to. But what I'm going to show you is some work that we have published over the last few months in the Proceedings of the National Academies of Science, as well as in the form of a OECD report, to look at what it would actually cost countries to phase out antibiotic growth promoters.
Yeah, just a minute. Don't forget to say next when you want us to change slides.
Yes, I will say that. I will say that.
Where are you now? What slide are you on?
Yeah, so slide 2. Are you able to hear me?
Yes.
Okay, great. So slide 2 is, just to set the context, we published this analysis of global antibiotic consumption in the human sector roughly about a year ago, and this was in Lancet Infectious Disease. And if you go to slide number 3, you can see that consumption patterns were very different across the world. Some countries have higher consumption, like the US, like Russia, for instance, like Australia, even Saudi Arabia. But if you go to slide 4, you see that the growth rate compounded annually between 2000 and 2010 is very different, again, across these countries. Across much of the high-income world, with the exception of Australia, consumption is either flat or going down due to a number of reasons, not the least the introduction of the pneumococcal conjugate vaccine, which has really taken taken off the number of children who are prescribed antibiotics under the age of 5. But meanwhile, overall consumption went up about 36%, with 75% of that 36% increase being concentrated in just the 5 BRICS countries: Brazil, Russia, India, China, and South Africa. And as you might expect, India and China, with their large populations, account for much of that increase. Next, we wanted to see, if you look at, again, if you go to slide 5, if you see the annual growth rate of standard units per capita, they are higher for China and India. However, actual consumption is still higher in the developed world on a per capita basis. So this looks a lot like carbon emissions, where rising incomes mean that China and India emissions per capita are increasing, but still they're nowhere near the levels per capita of the US, France, Germany, or the UK. Now, slide 6 shows another significant trend, which, as folks who are interested in antibiotic resistance, we should really pay attention to, and that is the significant increase in the global demand and production of meat. So if you look at slide 6, you can see that the demand for meat, particularly for swine and poultry, has been going up significantly. And this obviously has implications for the quantities of antibiotic consumed and the selection measure. Slide 7 shows that if you look at FAO data since 1961, the increase in output per input ratios have been fairly high. So if you look at meat production per head of livestock, that is also going. So that's higher for chicken, also for pigs, and also for cattle. If you go to slide 8, what we do know is that antimicrobials are used widely in the animal sector, and there are 27 different antimicrobial classes that are used in animals. They count them slightly differently than we do in humans, but most of these have key antimicrobial counterparts, and only 9 of them are used exclusively in animals. A lot of, I'm going to turn the video off. a lot of these antimicrobial classes for animal use are similar to ones that we encounter in humans: macrolides, penicillins, tetracyclines, for instance. And that obviously has implications for resistance on the human side. If you go to slide 9, you can see that there is a correlation between national antimicrobial consumption and meat production. So this is national antimicrobial consumption in the livestock sector, not in the human sector, in the livestock sector. And the only region for which we have fairly reliable data is the EU. I mean, thank God for the EU. If we didn't have the superb data collection that the EU has, we would know practically nothing about this problem. We do have some data from the US as well, but very, very aggregated, and some data from Australia as well. If you go to slide 10, you can see the results of that study, where we see that the largest consumers of antimicrobials in 2010 and 2030 are very different. In 2010, it is China, US, Brazil, Germany, and India are the largest consumers. But if you look at the graphs in column B, you can see that in 2030, China is still on top, but the consumption has doubled to more than 30,000 tons over that period of time. The US is slightly higher, but not too much different. Brazil much higher. India has taken over from Germany in 4th place, and then Mexico comes into 5th place. And countries in which consumption is going up a lot are China, Brazil, India, to some extent the US, and also Indonesia. Now, if you go to slide 11, what we did was we used a modeling method. What we did was we called up every country in which it was possible to get some data on antibiotic consumption in the livestock sector from whether the agricultural department or the ministry and so forth. So I had a team of RAs who spent a lot of time on the phone with this. And then whatever data we had, we then used as part of a modeling exercise, which also combined FAO stat data or FAO data from the gridded livestock map of the world, which shows us, again, where the livestock are, broken out by poultry, swine, and cattle. And based on that, we made these projections of antimicrobial consumption in livestock, which is what you see on the top of slide 11. And at the bottom in green, what you see is the standard deviation, which means to some extent it's reflecting the uncertainty in this. And you can see the standard deviation is obviously high for large parts of Africa. But then there are parts of the world for which we do know within, at least one order of magnitude how much antibiotics are being consumed in human and animal, in the animal side. If you go to slide 12, to summarize what we found that global consumption of antimicrobials in food was estimated at roughly about 63,000 tons in 2010. And it's projected to rise by about 67% to about 105,000 tons by 2030. If you're curious about how this compares with the human consumption, this is roughly twice, more than twice actually, the human consumption if you were to measure it in tons. Again, these are large confidence intervals, but this is roughly what we have. So 2/3 of our global consumption is going to the animal sector. And in hotspots like India, where you have areas of high consumption for industrial poultry, production is expected to grow by more than 300%. It's also true for certain parts of Africa as well, like South Africa and Kenya. If you go to slide 13, what we do see is that the price of antibiotics, as a feed additive has actually gone down over time, even as the price of broiler, cattle, and hog meat has gone up. We happen to have reliable data for Washington State, so that's why I put that up in front of you. But this is a general trend that the cost of the antibiotics as an input into production has generally either gone down or stayed flat, whereas obviously the price of meat has kept going up. And if you go to slide 14, you can see that the sales of antibiotic feed additives have also kept pace with the increase in production, whether it is beef, poultry, or pork. This is US data from 1950 to 1970. And it tells us that these are viewed as an essential ingredient in production, even if it is not clear that they are necessarily an essential ingredient in production. But obviously, most farmers will tell you that they are. Now, what we again did was we looked at antimicrobial consumption in the EU in the next slide, which is slide number 15, where we had very detailed data on antimicrobial consumption broken out by these pixelated maps, separated for cattle, chicken, and pigs. We happen to have these data also for certain other parts of the world, like South and Southeast Asia, greater uncertainty bounds, but certainly we knew where it was. And you can see that some of these high places of consumption, again, are, for instance, coastal areas of India in slide 16. You can see that much of the coast and South India, you should know, is much wealthier than the North, and therefore much greater consumption of meat in South India, also in Bangladesh and also in Pakistan, very high levels of consumption. And then also across most parts of coastal China, which is where the population really resides. Now, slide 17 shows us what the published literature tells us about how important antibiotics are as growth promoters in terms of the productivity gain for the animals. So, although this refers to the same study, Hayes, 1978, in a number of places, it basically is a meta-analysis of a number of other studies, which are unpublished reports and so forth. But we've tried to put together all of these numbers, and basically what we have is, the red dots on slide 17 and the blue dots. The blue dots are the percentage improvement in the annual, the average daily growth of pigs fed antibiotics over time. And the red dots are the percentage improvement of the average daily growth of growing to finishing pigs. So basically, one is the small fellows, and the other one is the big fellows, the finishing guys. But whichever way you look at it, you see that overall there does seem to be a diminishing trend in the percentage improvement of pigs fed antibiotics. These are all U.S. data, by the way, but we kept it as U.S. just to maintain consistency. Now, if you look at change in performance based on improvement in feed conversion ratios of pigs fed antibiotics over time, again, you see that it's a diminishing trend. You see that in the 1950s, you had improvements of 4.5% to 5.5%. You have between 0 and 1% when you get to about 2000. If you go to slide 19, if you summarize this, what you see is that in the 1980s literature, the average daily growth with antimicrobial growth promoters is always about at least twice, and in some cases about 5 times greater than what it is in the 2000s literature, implying perhaps that something has changed in the ecosystem of how these animals are grown, which makes the antimicrobials much less important. And veterinarians have thought about this, and they have some ideas about what might be going on, which is in slide 20. And what they basically say is, if you plot approach to genetic potential, so the genetic potential of, say, a chick when it's in terms of how healthy and big it's going to become, and the amount of improvement you can get from antimicrobial growth promoters, initially there's not a lot that you can really get when nutrition is really bad and when hygiene is really poor. But as you improve hygiene, nutrition, and herd health, you get from this phase 1 to phase 2 into phase 3. And phase 3 is where you get the maximum gains from feeding the antibiotics to the animals. Potential to a significant extent. You've also got the nutrition, herd health, and hygiene all down. Then the improvement over the control is quite small for animals that are fed antibiotics compared to those that are not, implying that perhaps for highly optimized systems, such as what we are now approaching in Europe and the US, the added value of antibiotics as growth promoters is probably very small or approaching that level on average. There might be some farms that still benefit from the use of growth promoters, but they would happen to be the least hygienic farms, or the ones with the worst herd health, or the ones with the worst nutrition. So if you took all of these data together and then we use these to also set out some baseline assumptions on productivity reductions and costs. So if you look at slide 21, we can really break this down into what the cost would be per pig produced of removing the antimicrobial growth promoters. So the same data on slide 21, I'm going to put it on slide 22 in the form of a graphic which is easy to read. And what we see is that on average, the productivity reduction in cost per produced pig by removing antimicrobial growth promoters in the US is about $1.34. Where does that come from? It comes from about 44 cents of excess mortality, which is the higher chance that the pig will die without the antibiotics. It's small, but still exists. There's excess feeding days, which means that you will have to feed the pig for slightly more days, about 1.6 more days to get to die, because you're not getting the gains of the growth promotion. There's some benefit in terms of averting the increased medication, because the pigs don't fall sick as much, and also there's some in terms of increased workload. But you can add this up and say, well, is $1.34 really worth it? Remove the antibiotics from all swine. I think what you're hearing from at least producers in the US is that on the one hand, they have consumer preferences, which are now strongly in favor of antibiotic-free meat. I think only in the last few years, consumers have even heard that there is an option of antibiotic-free meat, because earlier they were not even aware that the antibiotics were in the meat that they ate to begin with. So with that awareness comes now a demand. And when I hear now the vice president for policy at Walmart saying that his consumers are demanding antibiotic feed, and then I realized, well, obviously something is shifting here. There's a shift in awareness, and then the companies are doing the math, which is high demand from consumers, a very small cost of doing this, and what makes perfect sense for them to do this. Now, the challenge for us is to how to translate this message across the rest of the world so that the same message is heard in India, in China particularly, also in South Africa, Brazil, Argentina, and so forth. And that's really the challenge that lies ahead of us. Slide 23 is the potential loss in annual meat production following antimicrobial growth promoter withdrawal in percentage. You can see that the reduction is not that great. So it's either green or the light orange in most of the high-income countries. Where much of the cost will be in terms of the low and middle-income countries, especially the low-income countries, where meat production is not yet optimized. So here, the antimicrobial growth promoter withdrawal will cost money, as you will see in slide 24. The meat value lost is going to be significant, particularly in China. But then again, you got to see, is $3 billion a year. Is that worth it for China to get rid of antimicrobial growth promoters, given all the benefit on the health side? Similarly for Brazil, similarly for India and South Africa, Tanzania, and so forth. And that's the work that lies ahead of us. And I strongly believe that it's possible to do this as long as we're able to explain these numbers and make the case that the consequences of human health, even if with lockdowns, is still going to be important. So to summarize, the key messages are: we have had significant average annual consumption of antibiotics, across the world. The growth response to antimicrobial growth promoters is small in optimized production system. This is all slide 25. Growth response to antimicrobials is less important when you've got the other stuff sorted out: nutrition, hygiene practices, genetic potential of animals, and herd health. And if you go to slide 26, with no major changes in policy, global consumption of antimicrobials in the livestock sector is projected to increase by 2/3 by 2030. We have to do everything we can to stop that from happening, because that will place enormous selection pressure. Point number 4 is that these projected effects of restricting subtherapeutic use on livestock can vary very widely, which means that one of the things that our global action should do is help countries, particularly low-income countries, phase out antibiotic consumption by improving their production system. So, rather than the Netherlands or Sweden in the bilateral calling for India to do more on livestock antibiotic use, could offer to help on lessons learned on how to raise chicken, for instance, without antibiotics. And I think there's a great room for shared learning here, given that some of the world already knows how to do this. So this could have a significant impact that outweighs everything else that we might be thinking about in this area. Lastly, obviously, the economic impact, I think, is limited in high-income countries, and therefore there is no need for antibiotics in growth promotion in these countries anymore. Slide 27, just to say that much of this work is based on the work that the Global Antibiotic Resistance Partnership that has already had treatment action plans in 8 countries working on, and also in the livestock sector. One of the things that was, that we really need is to bring together this concept of One Health and get the veterinarians talking to the doctors. There's simply not enough of that happening. Slide 28 is to and to say that the slides are available online. Appreciate your putting with me on site, and I'll stop now. Thank you very much.
Ramanam. Thank you very much for giving us, for being woken up in the night to give us a great lecture. Time has been running fast in our session, so I suggest that while we have the workshop hour late in the afternoon, we'll also include you in it and have questions taken from the audience to you too. So now we have coffee and then workshops, and I'll see you at 3 in the afternoon.
Saved.